So good morning, everybody. My name is Mark Driscoll. I am the program manager for the Preventative Health Program with the Ohio AAP. And we have with us today Dr. Skylar Kalady, Dr. Alex Rakowski, and Heather Kristofsky-Razor from the WIC program. And we're excited for this presentation on food insecurity in Ohio. If we can go to the next slide. This is our CME disclosure. None of today's speakers have any financial relationship to disclose. So we're all clear there. And the next slide. One of our big initiatives with the chapter is to be working on our diversity, equity, and inclusion standards. So each of the speakers today were given a checklist of things to make sure that they're considering when creating this presentation. If you have any questions or comments about diversity, equity, and inclusion for the chapter, you can email our medical lead for the program, Dr. Chris Bowling, and his email is there. I'll be sending these slides out after the presentation today. And then that is all for me. I will go ahead and kick it off to Dr. Rakowski.
I guess good early afternoon, everybody. I'm Alex Rakowski. I work at the primary care clinic system for Nationwide Children's, along with Skylar. If you actually have time later on to look at that first slide, you'll see that poor girl trying to spell my name with the R-A, and in a couple of years, she'll try to spell Heather's last name. So keep her in mind. So here we go. The aims for this presentation. We're going to share a patient story, and I'm going to quickly define food insecurity and prevalence. And then Skylar is going to take over looking at the impact and then highlighting universal screening and the importance of it. And then Heather will talk about two of the largest federal systems and programs to help food insecurity. And I'll finish up with two more and then state and local resources. And then Skylar will talk about practice-based strategies for success. And then we'll open up for questions. And hopefully we'll have around 15 to 20 minutes for questions. So patient stories. So this is actually, unfortunately, pretty common. So a single mom with 3 young kids comes to clinic for a newborn follow-up visit for her youngest baby. Of course, has routine questions about newborn care. Unfortunately, universal screening was done, and it picked up her bigger concern about feeding her family. So how can we provide some support? And this is really the whole topic of this conversation. So what is food insecurity? I'm going to start off with more aspirational definitions. So this is not the USDA definitions, which you're going to hear about for the rest of the talk. I'm a research type, and I think this is important to kind of put out there for those of you who are interested in food insecurity and combating it. This is what NIH has been using for some of their research grants. And they actually have 3 definitions to kind of broaden up the way we think about it. So they focus on food insecurity, which I think is a traditional definition, which we'll get into. Number 2 is at risk for food insecurity. And these are families that you're trying to predict are going to drop into food insecurity in the near future. Examples: recent immigrants that are about to lose some of their resources. Somebody got incarcerated, a person who has illness and they have a day job. We saw this a lot with COVID, for example. Recent death in the family. So again, how do you predict and how do you pre-plan for this family, at the level of primary care to help them with their food insecurity that may be coming up? And number 3 is limited access to quality foods. I think everybody knows about food deserts, where there may not be stores that provide high quality foods. But there's also the reality that a lot of our families may not have storage space to refrigerate large amounts or freeze large amounts. There is one clinic in our system when they just had the residents ask quickly how many people have an oven or a stove, and the vast majority of their families did not. They use basically like stovetop burners that you plug in. So that really makes a difference to the quality of food that you can actually work on. So again, a topic which is we won't talk a lot about today, but of importance when you look at food insecurity research. So now your classic USDA classification, and they focus on the positive, the food security. And they break down the entire population into 4 categories: the high food security, the marginal, which basically may be capturing some of the at risk, low food security, and then very low food security. And very low food security is almost like a daily basis disrupted eating patterns. This is a survey upon which this is built. The first three questions are more focused on 6 months or more of a acute to subacute. And then the 12-month questions, which are 5 and 6, are really trying to focus on predicting down the road or get a longer kind of view of the situation. And that's the scoring. So score of 0 is high food, score of 5, 6 is very low food security. And then 1 is marginal, and 2 to 4 is low. So what's the prevalence? Well, actually, I have one more here. So if you actually look at the USDA definition, their focus really is on food at that time or within the last 6 months to a year. But they try to put in some questions that kind of go into at risk. And I think we all are aware of the fact that there are various factors that drive food insecurity that can help you predict that this may come up in the near future. So that's when you're screening for this. It isn't just a single screening, but you're looking at other aspects that could impact this down the road. So now prevalence. So I'm going to look at this two ways. Again, this is all USDA data. The first is really more on an individual basis. So this is looking at among US households, but individuals in that household, looking at, again, low or very low, 12.2 nationally overall. And then of that 12.2, around a third or 4.7% are very low food insecurity. If you look at it from the next perspective, which is, next slide, please, which is going to be actually at the household level. And this will make a difference when we talk about screening. But at the household level, again, kids live in houses, they live with families. So you have a higher number because the questionnaire, again, the first one's looking at asking individuals and then extrapolating to kids. This is more looking at a household and then seeing how many of those households actually have children in there. So around a fifth of all households in this country are considered food insecure, which is low or very low. Of that 1/5, around half of them are going to have food insecure, have children as well. And a food insecure family is usually going to have issues either with a food insecure adult or kids or both. Next slide, please. So how do we compare? So if you look at Ohio, overall, we're a little bit better on some of these compared to national. But again, it's no great shakes. And honestly, we'd love to get those numbers down to like single digits for the low and like non-existent for very low. So if you actually look at number of households based on USDA, it's around 1 in 5 in Ohio. If you look at risk, where you're capturing a larger number, probably the estimates are 1 in 4 to 1 in 3. And then if you're looking at quality of food issues, you're probably looking around half of the kids in the state have some kind of impact by food insecurity or potential food insecurity impacting their lives. And this is our clinic system. Again, our questions focus on the family or the household. So this isn't on an individual, like, is your child food insecure? It's really like, is the house insecure? So you're going to capture a little bit different than some of the other numbers I gave before. But as you can tell, in almost our entire system, we're well over the Ohio and the US lines. All right, Skylar.
All right, great. So hopefully we've demonstrated, unfortunately, that food insecurity is very prevalent in all our communities in Ohio. So why does it matter? What is the impact on children? Obviously, we know it is unfortunately great. So if one way to start thinking about it is to think about Maslow's hierarchy of needs. And what you see is way at the bottom, food is one of those physiologic needs, which if we're not meeting that, families can't even begin to think about other things like safety, much less doing well in school or adherence to medications for chronic diseases. So this is really critical that we address this. The effects of food insecurity are massive, as you likely know. So some of the things that have been identified are stated here, and we're going to go into these on future slides, but health status, developmental and educational concerns, mental health issues, and then families have food anxiety, diet monotony, not being able to have the ability to sort of change up what they're serving, decreased quality of what they're eating. They might have sufficient calories, but have terrible, nutrition content. and then just not enough food. So some of these may be obvious to you, but many may not. So I wanted to call your attention to the Food Research and Action Center. This is a center that is working to focus on nutrition, health, and well-being in families struggling with poverty-related hunger in our country, with many modalities. And this is a great toolkit if you have chance after this to look up one extra resource we would recommend this, Screen and Intervene, and many of the concepts that we quote are from this. So getting back to impact on patients, what about poor health status? So growth can be impacted for infants, both with weight, height, and head circumference. We see patients who are underweight, just not enough calories, or overweight. They're getting calories, but the nutritional content is terrible. And common deficiencies include low protein or iron deficiency anemia. We see a higher prevalence of dental caries, and families are often going to the emergency room more often with lots of care gaps. They have so much going on, they're not able to come in to their primary care team, where hopefully we would have had the opportunity to screen and address. And then another concern is that these issues of child malnutrition are not limited to childhood. They can increase your risk for the adult diseases mentioned below. Other concerns are developmental concerns. So when newborns are born to moms who are food insecure, they're more likely to have a lower birth weight and birth defects or complications. And as those same children get older into their infancy and toddler years, there are more developmental delays. And we know that early brain research is so critical, in the first 3 years. So this is a big risk. And at all ages, children that are struggling with food insecurity are doing poorly from a cognitive standpoint and having more behavioral and emotional distress concerns. This links to education, moving on to out of our toddler years to our kindergartners. Children that are food insecure as kindergartners, that predicts lower math and reading for the next 4 years. So that's really concerning. And then we know that performance in elementary school, again, predicts their higher education attainment. So we really need to identify this early and mitigate its impact. We see mental health problems in families and children struggling with food insecurity can create that toxic stress and develop those preoccupation or maladaptive behaviors related to food that can last for years or longer. And children living in food insecure families, not surprisingly, have higher rates of behavioral outbursts and trouble focusing. And many of them are also diagnosed with ADHD. And then teenagers are struggling at higher rates, where we already have high rates of these things across our populations, but those food insecure have even higher relative rates of depression, anxiety, and even suicidal ideation. So putting these things together in that FRAC toolkit, Alex, who you just met, had this quote that they thought was so important they included, and I wanted to read it. I think it's really thoughtful. So the lack of adequate food not only has important physical impacts on our patients, such as not focusing in school and fatigue, but more importantly, has emotional impacts. As humans, we love to feed those we love. Parents that do not have the resources to feed their children adequately definitely feel that they are not showing this love, and the children may, with time, feel let down, not only by their families, but by society in general. Thus, we are screening for this to both help solve acute issues, but also longer-term human development issues. So this leads us into screening. So let's talk about universal screening for food insecurity. As has been alluded to, a lot of times hunger is right in front of us, and we just won't know. Many families are not going to bring this up if we don't screen. And so we want to identify those 1 in 5 kids or even higher in your local community that are struggling with this and be able to intervene. So the AAP has come up with 2 validated questions to address food insecurity, these hunger vital signs. The first is, within the past 12 months, we worried whether our food would run out before we got money to buy more. And the second is, within the past 12 months, the food we bought just didn't last and we didn't have money to get more. So anyone that responds as often true or sometimes true for either question would be deemed food insecure. So how can we implement this screening? So maybe you've done it in your practice, or maybe you're figuring out how to get it going. So there are a couple considerations of how to implement this. What questions would you use? Would you choose those two standalone questions, or might you include those in a broader screen for social determinants of health? When would you administer these screening questions? Would you give them annually at the well visits or more often, recognizing that data completed, could change very quickly? How are you going to do this? Would you have someone give these out at registration when someone's checking in? Would it be the rooming team that's responsible for giving out these screening questions, or will it be the provider seeing the patient? And do you have opportunity to do it in a paper fashion or an electronic fashion? What's available at your practice site? And then if you're spending time to screen, how will you know that you're doing a great job? So how are you going to track where your baseline is and then be able to look and see how much improvement you've made? So not everyone can do all these the same way, but again, just think about your practice setting and what opportunity there is to implement these screens. At Nationwide Children's, we've chosen to incorporate it more broadly into our social determinants of health screening. And so our families receive an electronic tablet with this questionnaire as they check in with our registration team once a year. And after they have filled this out in a confidential manner, their responses show up in our electronic health record. While the family's being roomed, our rooming team looks to make sure they've been completed, and if they haven't, they give another prompt for the family to do so. And then it is the provider's responsibility to review the responses and address them. So there's a lot of challenges to consider in implementing screening. And this is a sensitive subject, and so we really want to create trust with our families so they feel that they can disclose, that there's no judgment, but we're really there to partner with them. We do need to recognize if someone doesn't answer, that we have to respect that. We want to think about offering our screening in multiple languages, so we're really addressing all of our families. And we need to be honest that this does add time to processes, but it's important. We want to know that responses can change, as I mentioned. So even if you are doing it annually, something that was mentioned, and filled out 6 months ago may not be reflective of what the family is living with right now. If you're on paper charting, do you have opportunity to get it electronic, or if you're using, can you do something where you'll be able to manage this? And in a busy clinic setting, we do want to make sure, what do we do if we miss the answers of our families? So that's a high risk situation if they're bold enough, trusting enough to share that they're having insecure, but we don't address it. So what would be your backup plan if that happened? All right. So imagine your families have disclosed some concerns about food insecurities. How can we support them? So let's start with the federal programs. There are many. So here is an array of all the government programs, and we're going to go into each one. So first, SNAP, the Supplemental Nutrition Assistance Program. This is the largest federal nutrition program, and you may have previously known it as food stamps, and it supports patients of all ages, not limited to children. So some things that are pertinent about SNAP are they get monthly benefits. Families can use an EBD card that's sort of loaded, like a debit card, at grocery stores, farmer markets, food retailers that accept SNAP. The benefit is small. It's $28 a week per person, or $1.39 a meal. All right, so think about that. That's not a lot, but it's something. So if families qualify, we want to connect them. Usually, or always, sorry, the eligibility is that your gross income has to typically be at 130% of the federal poverty level to be eligible. It can vary a little bit. And so that is a little bit about SNAP. Some other pertinence, pros, it really has had some great data showing it's very successful. It is present in Ohio. And there are some double up SNAP options, sometimes with fruits and vegetables and other things. So sometimes that, dollar can be actually $2. Some challenges with SNAP, not everybody qualifies. So some families that do have Medicaid insurance will qualify for WIC, but not SNAP. And some families, run out. This is really supplemental, but not sufficient. And finally, in our families who are immigrants, there are some real challenges. You can apply. It's really important you feel confident telling these families you can apply for and receive SNAP without any immigration consequences. You would not become a public charge. And some non-citizens do qualify for SNAP immediately. Those would be refugees, individuals with asylum, and victims of trafficking. And this also includes children under the age of 18, usually. They're usually immediately eligible, even if their parents are not. Unfortunately, SNAP is not offered to undocumented non-citizens. So that's a little bit about SNAP. Let's move on to WIC.
All right, so WIC, the official name is the Special Supplemental Nutrition Program for Women, Infant, and Children. We are a preventative nutrition program, and we provide nutrition education and counseling, breastfeeding education and support, along with those supplemental and nutritious foods, and referral services. Next slide. So who do we serve? Just like our name, women, infants, and children. We serve women who are currently pregnant, women who are postpartum up to 6 months after birth. If they are not breastfeeding, if they are breastfeeding an infant, they are certified up to 12 months of age, and who have an infant under 6 months of age. That also includes women that have had miscarriages or fetal demises as well. Regardless of how early in their pregnancy, they can get benefits for up to 6 months. Infants from birth to 12 months of age, and then children from 1 to 5. Next slide. So eligibility, before I forget at the end of this slide, we made a good point in SNAP that they do not have qualifications for undocumented workers or undocumented citizens. And so WIC, that's not a qualification. So we look at their residential status as if they live in Ohio, but we don't look at like their immigration status and stuff like that. So it is still a resource that they are allowed to have. Identification, they have to provide a personal identifying factor to their local clinic. They do have to fit in that category of pregnant, postpartum, breastfeeding, infant or child of 5. Like I said, they have to live in Ohio. They don't have to apply to one in their specific county as well that they currently live in. They can go to neighboring counties, whatever is closer or easier for them. Some counties have higher caseloads than others, and they can get in faster in certain counties if they're closer to. The medical nutrition risk, that's determined by our local WIC health professionals. They are dietitians, they are nurses, DTRs, diet techs. And so they go through while they're doing the appointment to determine if they have a nutritional risk. There is always something we can find. And so that's usually not like a quote unquote real factor that we look, but that is a federal requirement for it. Physical presence, applicants have to be there, and that includes the children. So if they're applying to have their child in or a part of WIC, then that child has to be with them. And that's because we get anthropometric data. So we're looking at height, weight, and hemoglobin for them. Income, they are at 185% of the federal poverty line guidelines. So if a family of 4, they are grossing about $55,500 annually, they are income eligible, and that's total for the family. We also have objective eligibility as well. So Medicaid, if they already do receive SNAP or TANF as well, then they automatically receive WIC, and we don't even have to look at like pay stubs. And this eligibility is based on federal requirements, not just Ohio. Next slide. WIC benefits that they are getting. And another big thing that Dr. Kennedy also said was within the past 12 months, you know, we talk about if they run out of food or if the food that they bought did not be sufficient for them, we ask those questions in their WIC appointments as well. It's part of their paperwork that they have to fill out. The health professional is asking those questions. And majority of the people that we see, at least when I was helping out in the clinic this last month, pretty much everyone I saw is saying, yes, they are having issues. They are running out, especially, or they don't have enough money because of the increased price in groceries and are using pantries. So another resource that we will provide is giving them community resources that can help them kind of bridge that gap that WIC is also missing since we are supplemental. We provide milk, yogurt, cheese, eggs, breakfast cereals, and they are whole grain breakfast cereals. People have to, or producers have to provide us with the food that they would like to put on WIC. And then we go through the nutritional guidelines of it and make sure that it would be qualifying. We have juice and canned fish as well. Fruits and vegetables, that's a money voucher. So they have the WIC card, and the money is basically just loaded to the WIC card to count for and it goes towards their fruits and vegetables. They don't have to use it all at the same time. They can just buy, an apple here and there. It takes that dollar amount off of whatever it was costing that time. So if things are on for sale, they can get stuff, they can get more that month, or however they're strategic on how they're buying it. It can also be fresh, frozen, or canned. Peanut butter, canned or dried beans, whole grains. That's not just bread, it's pastas, it's tortillas, also a bread, and then oatmeal as well. Infant cereals for those kiddos that are under 12 months, and prepared infant foods like the vegetables. Fully breastfed babies that are getting no formula from us whatsoever are also getting infant meat as well. That's what I call it. It's the baby foods that is meat pureed. They get those to help kind of bridge that iron gap that some of those breastfed babies are getting. These benefits are examples of everything that WIC offers, including the infant formula. But not every participant will get like all of these. It's really dependent on what category they're on. So pregnant women get stuff different than postpartum women, than breastfeeding women, than the infants, then children from 1 to 2 also have a package of their own, and then 2 to 5 have a package of their own. And it's really supposed to be tailored to their nutritional need within that stage of life. Next slide. So my biggest thing that I focus on as the peer program coordinator is breastfeeding. And so we also have breastfeeding education and support. It is integrated into the education of all pregnant and postpartum WIC participants, even if they are not wanting to breastfeed or they're unsure, we still give them that education. Their milk's going to come in regardless. And so we want them to be prepared for that. And give them options of maybe you don't want to breastfeed, but maybe you want to donate. If you don't want to breastfeed at all, that's totally fine as well, but your milk's going to come in and you do need that education to support yourself. And on our staff, we have IBCLCs. We also have lactation consultants, and then breastfeeding peer helpers. And those are WIC participants that breastfed their babies. And then now they work for the clinic and help their peers in their community. And if you have any questions on WIC, there's my contact information. Back to Dr. Rakowski.
Thank you, Heather. And I'm going to finish up with 2 other federal programs. The first is Combined, which is the school lunch and breakfast program, daycare and after-school programs. And for a lot of families, this will be the largest benefit because it's 2 meals per child per day. A lot of schools have been going to what we call total eligible. So if not every child qualifies for these programs, and the qualifications are more along the lines of WIC FPL compared to SNAP federal poverty level, they can ask for total eligibility so every child in the school can get some of the free meals. And that commonly is supported by a private-public relationship. And this is why it's important to encourage school attendance. It's just a nice way for the kids to kind of get the meals. It also includes, again, daycare and after school, up to 2 meals per child per day. Unfortunately, there is also a summer program that's the unfortunate part is it's not very utilized. And there are some counties, when they looked at it, like only 9% of the kids or 9% of the families were aware of the fact that they could get similar resources during the week. Especially if the child was in daycare, they were aware, but otherwise not aware. So a way to kind of work around this is to give every family that qualifies for SNAP an electronic benefit transfer called a summer EBT or SunBucks. This replaced the pandemic extra money that was given to families. And while it's not a huge amount, it's $128 per child per summer, it does help out. And there's been more promotion to summer nutrition programs, especially for children who do not go to daycares or camps. So a lot of the local libraries, for example, Hilltop Library, will have free meals twice a day for kids to come in during the summertime. So it's a nice way to kind of get the family served in an educational setting or a recreational setting in the summertime. So that ends the federal programs. Let's talk about state and local programs. And these can be overwhelming. And the way we teach the residents is to break it down into 4 categories: food banks, food distribution focus, meal sites, and then seasonal. Let me start off with the food banks. There is a slew of food banks in this state, and next slide I actually have a way to see if you have a food bank near you. Most of them require proof of citizenship, which again we talked about before. Some of them do not. For example, Our Lady of Guadalupe Center here in the Columbus area, you can go to their food bank without having to show immigration papers. Number 2 is food distribution. And this isn't really meals. This is essentially getting some food for the weekend. And there are some programs, and I'll highlight one of them a little bit later on, where children can get something for the weekend for home, and then also meals to families and clinic, which we are piloting here, and some of the other sites in the state have also piloted. Number 3 is what people think about with traditionally for meals. And these are a lot of local churches, synagogues, mosques, community centers, even schools that will have variable schedule lunch and dinner based kind of meals. Huge resource. It is very variable, but it is something that if you can keep up with your area, is an amazing resource for our families. And it's amazing coming from Pennsylvania initially, just how many sites there are in this state that have things available for their local people. And then lastly is seasonal. There's the veggie van in the summer, and then usually around Thanksgiving and then the holiday Christmas season at the end of December, there'll be some specialized season food distribution programs that you do not have to use an EBT for, but are just have it available. And then one last thing I want to bring up is that at any single time you can call 211, which services most of the counties in Ohio for discussions about emergency food. And there are ways to get food, even brought to your house if there's an illness in the house or a disability and you just can't get to a food bank or to a meal site. So this is the food bank. This is Fresh Track. This shows the major food banks in the state. They're the blue dots. But there are other food banks in this area as well that can be much smaller. And there is work being done to kind of put them all into a massive database that you can just look up by zip code. And speaking of that, if you guys want to take a picture of this on this QR code, we have this, but this is actually like a national thing as well. But if you open this up, this will actually give you resources for dozens of issues in about 100+ languages. So an amazing resource. If you look at the food, for example, I speak Ukrainian. So I actually looked this up in Ukrainian the other day, and it listed the food banks, the meal sites, how to get into SNAP and how to get into WIC in Ukrainian. Some places did have it translated. Some of it was Google Translate. So, the grammar's not great. But it's an amazing resource to kind of be aware of. It's a little overwhelming for families. So it may be up to clinics to kind of do some of the homework and find things that are relevant to the families that they serve. Next slide, please. And then CAP for Kids is another program. And then CAPS for Kids is essentially a national, it's called Community Action Program, I believe, for kids. A children's advocacy project. It's in like 10 or 12 different cities. We have one here in Columbus. It actually has up-to-date information about multiple things. So in this slide, we're highlighting food. Again, a little overwhelming, but it will list things by category and also list things alphabetically. So again, for families, if they have the time or they have a computer that they can work on, nice resource. If they don't, something up for the clinics to kind of look up for the families to help them. Next slide. And then lastly, I talked about some of the weekend projects. And the big one in our area is Children's Hunger Alliance. They sponsor meals and snacks to in-home child care providers, child and Head Start programs that may not be involved with the 2 meal a day program. And then the big thing is weekend meal boxes, where actually the child goes home from school with enough food for about 2 meals over the weekend to kind of help out with the child hunger. And then lastly, they've been involved with several clinics in the state, but we now developed something called the Snack Pack. courtesy of several of our residents being involved with this, and all 14 of our primary care clinics receive between 200 and 300 snack packs per month, and we just give it out to the kids. So it services about 36,000 kids annually. Next slide.
Great. And just one further thing to emphasize, Children's Hunger Alliance serves the entire state. So they very well may be partnering with, organizations and childcare centers and schools near you. All right. So then now that we've shared sort of federal and local resources, we want to just get into sort of how to connect families, right? How can we bridge that gap? So a couple strategies we just wanted to raise, recognizing people work in different environments. So first is how can we universally educate people? So can we print out posters? What written handouts would make sense? Utilizing QR codes, in waiting rooms. Can we put these things, on the walls in your waiting rooms, in your clinics, if someone's in the room? Another idea would be an audio recording when someone's calling for an appointment and waiting on hold. Can we be providing education about resources? Another way to think about it is who's screening positive, and when they do, what are we going to give them? How are we going to connect them? So what would make sense to print out in paper with these sort of local resources as well as federal, or would a QR code make sense? Do you have an EMR, and can you embed something in the EMR? For example, if they screen positive for food insecurity, something automatically prints with resources. Or could you manually add a dot phrase that you create with your local resources? No one can do this alone. So who can you work with in your environment or in your community that can help in the moment or as follow-up? Do you have social workers you partner with, community health workers, all of these critical people that are all interested in this area? Your WIC liaison, your dietitians, who in your community can you partner with? And then if referrals are indicated, how will this get done? So would this be a paper thing, an electronic thing? Would it be something you initiate, or does the family call directly? Are you going to look for closed loop communication so that your referrals actually were completed? Some considerations to see what would work for you. Here's an example of just one of the FRAC posters in Spanish, just talking about federal nutrition programs. All you would need to know is it exists. You could print it out in Spanish or whatever languages are common in your population. Here's an example of just a written handout that we've created locally. I'm just telling our families how to apply for WIC. So we just hand this to them. Our goal is newborns coming in for their first visit, making sure families know that if they're eligible, this is how they can connect with WIC so that they can get those 5 years of benefits. Here's an example of a dot phrase that we've created. Again, it's a summary of sort of our local resources as well as the national ones and how to connect. And so maybe using that QR code that Dr. Kowski highlighted, you could pull together the local resources where you are. And then in terms of team support, what is our experience? We are sort of lucky to have social workers in most of our clinics. And we love when the family is interested to do warm handoffs in clinics where our social workers will see families that have identified social determinants of health risk factors and specifically food insecurity. And we definitely prioritize families that are not English proficient, as it's just even harder for them to connect with the systems. We also are working with some parent coaches and community health workers to really help in this regard, sort of one-on-one when the family is present. But there's also a huge role for asynchronous follow-ups. It may be that those people above aren't available in your clinic, and sometimes they're not in ours. Or maybe the family's not interested in having the conversation. They want to have it privately when their children are not present, or they're just in a rush. And let's be honest, you're busy, you're closing your charts, and oh my gosh, you see a positive screen. How do we address that? So we also have care navigation. We work with Partners for Kids, and they do some phone follow-up to connect families to resources and address concerns. So we hope that we've shared some ideas of how to work in your clinical environment, but we also want you to think big and sort of zoom out and think about beyond your clinic walls. What role can you have? Think about, find the community programs near you and see how could you align better. figure out, where are those food banks? Where are your WIC offices? Do you have relationships with those organizations? Maybe you're a teacher, and could you embed some of this information into your learning education? Do you want to endeavor to do a formal QI project and really measure where you are and where you're going? Could you volunteer with one of these organizations and show your passion? Are you into advocacy and policy? Think about, who are your representatives? Can you write letters to your legislators to help support, growing these resources? And really, any way that you support your families to increase financial support, there's going to be an indirect benefit to help food insecurity. So we're really hoping that, in addition to taking some of these suggestions to your clinical world, that you also think outside and see what you're excited to pursue. So let's do it. It takes a team. Let's really work to end food insecurity in our state. It's a lofty goal, but we can only do it together. We also wanted to thank all of these people involved, local leaders at Nationwide Children's, our primary care network, our residents who have spearheaded a lot of these initiatives, clinical leaders, and local community partners. And with that, we would love to give a few minutes for discussion and see if anyone had questions or things they'd like to chat about. Thank you for your interest.
So there is one question about what's in a snack pack that we hand out in clinic. I actually have one here in front of me, because then you will come up. So again, this is just for snacks over a weekend for a child. So we have a sort of organic, it's not even mango, it's mostly beet juice. You have one of those.
Alex, there, yeah, just raise it a little higher. I don't think they could see. Perfect.
There's squeezable fruit, sunflowers, Teddy grams, not the healthiest choice around. We usually have crackers, and then usually some sort of meat. We try not to have anything pork related because we have a larger immigrant population, especially a larger Muslim population and Jewish population. So these are beef sticks usually, or chicken sticks. So that's a typical snack pack, and kids get them every time they're here. Again, it will just last you basically over the weekend. And we do try to have as little allergens as possible. So, for example, sunflowers instead of peanuts. The juice that we give has not any of the common 8 food allergens. But we do tell parents to open it up in the room to see what's available, what's not. And unfortunately, there's not a whole lot of swap out. We just get it from the Children's Hunger Alliance.
Yeah, and I would just say that with those snack packs, they are nice for someone coming in, say for an 11 o'clock appointment, who may be missing both their breakfast and their lunch at school, maybe acting out in the appointment because they're hungry, right? So we're able to give these. And, there are many organizations throughout the state that are working with different healthcare organizations to do something similar. We're lucky to partner with Children's Hunger Alliance, but there are many models like this throughout the state.
Plus, I think it also, the residents have mentioned this, it normalizes the discussion about food insecurity. So if you come in with snacks and you start talking about food, the parents a lot of times bring their guard down because, they're embarrassed about the fact that they may not be feeding their child appropriately. And it's an embarrassment for them. But now if you bring that up with something in hand, the families a lot of times will then turn around and say, do you have any extra? And then, why do you ask? Oh, by the way, we're really struggling with some food insecurity. And then that opens up a whole discussion. So it also has been like a nice breaker of ways to communicate with families.
See, the other question we had about the snack packs is if they're available for schools.
Yeah, so Children's Hunger Alliance has, for us, partnered with the clinics, but the main work that they do is partnering with schools and after school programs. And so, if they don't work direct to families, but they partner with organizations. So they, again, are in almost all the counties in some capacity throughout the state. And so schools should feel free to contact them to see if they have capacity to create a program with them, or looking locally if there's something similar with someone that they could partner with.
And then we have a question asking if you can kind of speak to EBT and the balance between healthy foods and education on healthier food choices.
Yeah, this is a harder topic, and hopefully all three of us kind of jump in on this one. So, and like a lot of gas stations, for example, have a sign, "We'll take EBT," and you sort of wonder what's in there that's EBT-able. Um, and again, speaking as a parent and a busy parent, a lot of times you'll go to the most convenient place, or if you don't have a functional way of transportation that you can rely on, you'll go to the place that actually you can get to on a routine basis. So the education is important, but it's also important to start looking into other options. So, for example, one of our residents has been looking into the Kroger home delivery program, and some of the Krogers, at least that I'm aware of in this area, or Giant Eagles or other home deliveries, instead of charging you the $5 or $10 delivery charge, if you have SNAP, then they will actually just like basically just ask for a tip if you have the money. Um, so it's kind of ways to get stores to bring to the families if they cannot get there. Does that water every food desert? No, but it may be a way to at least start producing a sahal, near the food deserts where you have at least some like efforts being done. Ultimately, a lot of the work has looked at food vans or mobile food clinics. I know Toledo did work looking at this. There's been work. I think Kansas City or St. Louis Children's did a large study looking at this, essentially seeing if they can get some of the local stores and food banks actually driving to a lot of the clinics. We have trialed that here a couple times. We're such a large system, it's kind of hard to do. But again, things to kind of consider in your community is, can we maybe get the local stores working together to come up with a walk-in, drive-through, what have you, way to kind of get in there, because the reality is that a lot of these places will not go into the food desert. So you almost have to come into the food desert to food.
Yeah, and that was my issue with it too. It's like if they offer EBT or they accept EBT and you're like, how do they have anything in there? But they could be the only corner store in the area. They don't have anywhere else to go. And we kind of see that that's definitely one of the blocks we have with WIC as well sometimes is they have to go to a WIC approved vendor. And it's all our big box stores, but maybe sometimes they only have that small town corner store that they have issues with. With WIC, they are getting the nutrition education. So that's part of the program is they do have to come in and get that education every single time they come in and get their card loaded, and their card holds 3 months at a time. So they don't have to go through like this long appointment every time, but to come and get their card loaded, they do have like a little handout on nutrition education of whatever that specific clinic is having for that specific month, to try and educate them on, how you can make healthier choices, even if they are having struggles with the type of foods that they are able to get or have access to.
Yeah, I'm not sure if there's any work being done in Ohio as far as like research is concerned, but in some states they have gone to the larger food meal places. So if there is a local church or community center that does meals 4 times a week, for dinner, the families are coming to, a lot of times, can we have a food truck that then has accessibility to use your SNAP there available? Again, something to kind of look into depending on the size of the community. But again, we tend to sort of silo all the food distribution things, but why not work together? And if you have a site that's like predictable, not variable, parents with their kids go there often, why not consider having like some discussions with your local supermarket to bring common SNAP benefit food on a truck, and they can just come in, shop, and then while they're eating the meal.
And I would just add, it's hard when you're doing shelf stable distribution, that's hard to, incorporate obviously anything fresh, but just knowing that there are benefits for fresh fruits and vegetables. And if we can identify what does exist in your community and make sure at minimum people are taking advantage of that, getting, those double, SNAP bucks. And, there, if you do have a farmer's market nearby, that's not available everywhere, but at least knowing what is available, because there are fresh fruits available in a lot of communities.
And that's only, the summer part, but with the farmers markets, we do some of the WIC programs will bring in the farmers to their clinics to try and, if they don't have access to be able to go to wherever the farmers market is in their community, they will bring the farmers to the clinics sometimes and have like big events. Or they work closely to where this is your extra SNAP bucks that you have here, because we also have extra in the summer where they get farmers market coupons to where they're able to get.
Yeah.
And we provide the education there as well.
Yeah, that's a great question. There's so much opportunity to learn from other states and from all of us. How do we actually deal with the food deserts?
Mm-hmm.
Hopefully that answers your question, Barbara. If you have other questions, you're free to unmute and clarify or ask further. And then if there are any other questions, we have a couple minutes left for discussion.
I'd like to thank everybody who's online that you have an interest in this. It's you know, when the residents hear a similar talk is eye-opening for them, and you know, this is a topic which is now getting some airtime, but we weren't commonly trained about this, and so I thank you for having interest and wanting to help the kids out in the area of food insecurity. It's so common.
I have a question about if you've collaborated with any dietitians on food insecurity.
So we have dietitians in the WIC program. That's a requirement for us. They have to have at least one dietitian in every county. We prefer to have dietitians as the WIC health professionals just because of that. With the Ohio licensure laws, all our quote unquote high risk charts. So if a certain risk code gets popped up, they have to have a dietitian sign off, including like low iron at certain points. And so they do all the nutrition education as well. It has to be overseen by a dietitian.
I was going to ask, I'm sorry, Skylar, go ahead.
Yeah, I was just going to say, we would love to partner more with dietitians in our community. Right now, that hasn't been the biggest bridge in primary care, just because they are so few and far between. And, you know, staffing the hospital and doing things, I know they do a lot in the hospital setting, but we would love to grow that relationship. It's just, you know, we want more of everybody.
And another big issue I was going to bring up is that some of our offices have a WIC office either downstairs from them or nearby, and the dietitians at the WIC offices are amazing. But some of us are further away, and like the clinic I'm at is about 50% non-English speaking. And it's hard to get dietitians through that, you know, have the time to then spend with an interpreter and talking to a family. But WIC is probably the resource we use the most currently. But it's hard to find dietitians.
We're having that issue in WIC as well. We're having definitely staffing issues of trying to find dietitians to fill vacancies.
And then we have a question about if you have any comments on the quality of the free breakfast and lunches in schools.
Oh, that's a loaded question, Barbara. So they are better than they used to be, but definitely not at the quality that they should be. I'll leave it at that. Sometimes the discussion with the school can make a difference. So they're mandated to have some healthy options with every meal, but they're not mandated to have healthy options only. But if you talk to the school, there is a way to kind of help them realize that the more healthy options you have and putting the money towards those makes a difference. So every school has a little bit of leeway, actually a decent amount of leeway of what they choose to kind of give to their kids. So I was just discussions with the local schools. There's a school not far from Hilltop Clinic where the residents went and actually talked to the principal, and their food choices got improved dramatically. Had they stayed, I'm not sure. This resident graduated 7 years ago, and she's now in the Akron area doing something similar. But it's usually a discussion with the actual school. And that's a great loaded question.
And I would just say I've been more involved on sort of the advocacy side of just making sure that there is access to school programs and that it's broadened to, you know, more eligible kids, because there's great data showing that when free breakfast was only available for certain people, it just wasn't utilized. And when it became universal and there was broader eligibility, many more kids took advantage. And so, you know, once you have volumes, then hopefully you can have even more impact on sort of addressing the nutritional content, but first access.
Yeah, it's definitely based on, just like Dr. Rakowski said, on like the staffing at each school and how the school board is with it. And the dietetic internship I did with Norwood Schools down in Cincinnati, he was amazing, but he was a chef and he like saw the need for good quality food and actually cooked like real ingredients. So he's not there anymore. So I would like to see how they changed, but it really just depends on who is running the program at the time.
And then we'll finish. There's a question if there's if other counties require eligibility at their food banks, if you know that.
I believe that most food banks in the state, I would ask you to look at that Fresh Track slide, because the food banks then have to list what is required paperwork wise to walk into the food bank. There are very few food banks that I'm aware of statewide that you can just walk in and get food for the larger ones. There are a lot of smaller, again, usually community, church, mosque, etc., to have small food banks just for either the local families in the area or members of their community. And they do not have requirements because it's all donated food. But the food banks that get some support usually do ask for eligibility or at least some documentation. But again, Fresh Track will have some information about each of those food banks that's on the map.
Yeah, I would agree. I would go to that Fresh Track, find the ones near you, and then there is some variability. So just figure out if you can share with families what the eligibility criteria is.
Yeah, 100%. Yeah, we make sure our local staff knows what's available in their specific community. We'll get asked on a state level, like, what are the resources? And we tell them the federal state programs, but they get more if they know their community resources.
If we can just go a couple slides ahead. I want to close by first of all thanking our speakers. This is a great presentation. I agree with Dr. Rakowski. It's great to see so many people on that are interested in the subject and kind of bringing awareness to this. On the screen here, you see our future webinars coming up for the preventative health program. If you're interested in those, I'll include a link in the follow-up email for registering for those. And then the last thing I'll say finally is if you will be claiming CME or MOC Part 2 credit for this webinar today, I'll also include a link in the email for how to apply for your credit. Again, I want to thank everybody for attending today and hope that you all have a great rest of your week. Thank you.
Thank you, everybody.
Thank you. Bye-bye.